Hi, I'm Constantino Pena. I'd like to welcome you to this program, Radial to Peripheral Techniques, the Best Practices, a case-based webcast. We're joined by two excellent faculty, Mary Constantino, she's a medical director at the Advanced Vascular Center in Portland, Oregon, and Parag Patel, professor of radiology and surgery at Medical College of Wisconsin in Milwaukee. So welcome both of you to this webcast.
Thank you.
These are our faculty disclosures. And our program today is provided by North American Center for Continuing Medical Education, an HMP global company, and it's supported by an educational grant from Cordis. Our learning objectives today will be to identify peripheral arterial disease in a patient and determine the best course of treatment, understand the benefits and risk associated with radial access for peripheral interventions, and then to be able to perform endovascular interventions after assessing the patient from the radial artery, from accessing the patient from the radial artery. With that, we're going to start with our first talk. It's going to be Dr. Patel. He's going to discuss an overview of PAD and access points, when it works and doesn't work.
Thanks,
Dr.
Tino.
Patel.
Appreciate it. Nice welcome and great to be joined by a good group here. So I'm going to set the stage a little bit for radial to peripheral, give you a brief overview. As you all know, 6.5 million people are estimated to have PAD in the United States, and that number is only growing. The risk factors are quite high. In fact, they're not going away with tobacco use, diabetes, hypertension, hypercholesterolemia, not to mention chronic kidney disease and obesity. And unfortunately, the U.S. Preventive Services Task Force does not currently recommend routine PAD screening in asymptomatic patients. So this means that PAD continues to remain underdiagnosed. We just don't see enough of these patients until they come and present to us at more advanced stages. Their presenting symptoms classically could be claudication. However, many will present at their initial stage to a clinician with CLI, that is rest pain or non-healing wounds. Medical management and obviously risk factor modification are the mainstay, but revascularization still currently plays an important role. All patients with CLI have a role for urgent revascularization, and a subset of patients with claudication, particularly those with lifestyle limiting or more proximal disease, would also be candidates for revascularization. As far as endovascular treatment of PAD in general, we've seen a significant increase over the past decade, probably 2 decades, and this is owing to, I think, a number of factors. There's an increased need because of aging population with vascular disease. We've had increased focus on training across vascular specialties, and the device development. This is the aspect where we've had significant improvement in crossing wires and catheters, re-entry devices, lesion modification devices, implants, and drug delivery. This has all helped pave the way for an increased utilization for endovascular treatment in PAD. The majority of endovascular interventions have been performed via transfemoral arterial access. And why not? The common femoral artery is an easy target. It's trained and has a long-standing history, relatively large diameter, so it can accommodate most devices. But unfortunately, there are some detriments. Some of our patients have large and inaccessible groins. That may be because of size, maybe because of a reoperative groin, and may cause complications to the actual intervention itself upon removal of your access. We have other approaches to try to make that access more amenable, but I think there are routes to go perhaps that might be more favorable. So in this vein, we've looked at alternative access options, and these have all been reported. Brachial artery can be anywhere from very high near the axilla or just above the antecubital fossa. Axillary is literally mostly anecdotal, percutaneously. That's rarely performed now. Radial will be the focus of today's discussion. But of course, it is important to mention in the setting of peripheral lower extremity revascularization that pedal access or antegrade SFA access and other emerging techniques have a significant role in improvement of the patients here and success in these interventions. As far as pedal access, this is obviously good for tibial or distal fempop lesions when they're not accessible from above. And you can do this percutaneously, either fluoroscopically. In our hands, it's typically under ultrasound guidance. You can place a wire through and generally do a sheathless type of approach. However, the advent of radial has been preceded in the peripheral environment by the coronary literature. Early on, the rifle study demonstrated significant efficacy in transradial versus transfemoral arterial access with a significant decrease in access site-related bleeding and overall reduction in clinical adverse events, namely hematoma or access site-related problems, as well as decreased hospital stay. Much larger number of patients in the Matrix study found the same thing. And so clearly radial to coronary, given the distance and shorter distance from femoral to coronary that radial to coronary can afford, and the low profile has shown a benefit in this particular access in this patient population. Radial to non-coronary was then soon to follow. Out of the Mount Sinai group, over 1,500 cases were reported in over 900 patients. And these were mainly visceral artery catheterizations, including liver-directed therapies and renal interventions. However, a number of pelvic interventions for fibroid embolization or peripheral interventions, namely in the iliacs, were performed with extremely high technical success rates and very low complication rates with relation to the access itself. So this comes to bear the radial to peripheral environment, and as we've seen, reports on radial to coronary artery stenting or carotid artery stenting, radial to iliac interventions, and then ultimately transradial versus transfemoral for iliac and femoral popliteal interventions have now been reported in the literature in the last 5 years. And this is where the burgeoning growth in this particular access and the devices that need for success are presented here. So when does it work? I'd say aortoiliac disease, well, let's talk about that segment first. The length is generally not the issue. I think most of the devices that we have now, with some of the advent of longer thin profile sheaths and longer wires, allow us to get to the distal aorta and iliac for management of these patients. However, you do need a long 6 or 7 French sheath, and with thin-walled sheaths now, we do have these in 90, 100 centimeter lengths, and you can do angioplasty, and any bare metal, self-expanding or balloon expandable stents can be used. The device profile does become an issue though, because currently there are no iliac stent grafts that meet transradial access needs currently from a 6 French platform. Obviously, if you have a more proximal access in the brachial or higher, you have an increased risk of access site complications, and so therefore a low profile iliac stent graft for this disease segment is still an unmet need. As far as proximal infrainguinal disease, low profile sheaths have already been developed in 120 and 150 centimeter lengths. We have guide wires, and they come in varying lengths, and we obviously could need more depending on if you're looking for crossing guide wires, support guide wires, and hydrophilic guide wires of the appropriate lengths to go from transradial down to the pedal access. Support catheters of appropriate length, and then angioplasty balloons that are either over the wire or rapid exchange, as well as self-expanding stents. These are the things that we currently need in the market, some of which we already have come early to bear, and we'll show some case examples to follow. Atherectomy, really, there's one device that has a 200 centimeter length. It's the CSI Diamondback, but it is otherwise limited in its applications in this setting. When it doesn't work, distal infrainguinal disease poses different challenges. I think the challenge here is that device profile isn't so much of an issue. Those small vessels generally do not require a large profile to deliver any intervention. Most of the devices in this area can be done in 5 French and in some cases 6 French, but everything else from an angioplasty or a small profile stent can be done with relatively low profile. It's the length that becomes the primary issue. In this instance, when distance becomes that great, the pushability, crossability, and torqueability of your devices becomes a point of issue. So when length and profile limitations become an issue, that's when distal lesions require a stent. For example, do you need a self-expanding stent in the popliteal artery? Do we have a stent long enough that's readily available? The need for reentry. Currently, from a low-profile system, we really don't have anything that's long enough to allow for appropriate reentry when you're subintimal. And then drug delivery systems, namely drug-coated balloons and drug-eluting stents, really do not have length delivery systems that will accommodate the distance needed from a radial to a distal peripheral access. Plaque modification, we talked about briefly, whether that be atherectomy, a calcium scoring, or lithoplasty. We again are severely limited in overall lengths, so there are some areas where it just doesn't work when you need those specific devices. In summary, many peripheral vascular lesions can be treated via transradial access with the current devices on the market, namely those in the more proximal aortoiliac and proximal femoral lesions. But if you have an isolated angioplasty treatment strategy, you might be able to get more distal lesions treated, and I think we'll see some cases shortly. There's clearly an increased interest in development of suitable transradial access devices, namely the length and profile needed to treat these more distal lesions. But still, there are significant unmet needs when treating lower extremity PAD via transradial approach as opposed to transfemoral.
Well, Parag, that was fantastic. I just to highlight some of the points that I think you made that I think we're going to keep talking about is really looking at the limitations in terms of what areas do we need longer devices and which areas do we need more diversity of devices, right? We talked about drug-coated technology, right? If we think that's that much better, do we need to develop that? And then you looked at and talked a little bit about when you're working from the radial, like the size of it really may not be a problem. So diameter size, right? Usually a 6 French and a slender 6 French, we should be able to get a lot of different things through there through a thin walled sheet. Right. But getting those devices in, and I think you brought up some good points, and I'm sure we're going to reiterate and build on some of these. And exactly when you make the choice, right? When, why to go radial in the access? Dr. Constantino, great to have you here. Why don't you lead us off in some cases?
I'm imagining an OBL with all of the devices that we're going to need in the future once all these links are developed. We already have to keep so much inventory, we'll have to double it when we have radial links. So I have a couple cases here. Again, thank you for inviting me to speak. I do radial artery access quite a bit for body intervention, and I think when I started doing it, they didn't quite have the 150 centimeter microcatheters, and so over time, as these microcatheters and wires have gotten longer, it's really enabled us to do quite a lot in the body, and I prefer radial. I'm a radial first person, so I do radial as much as I possibly can. I also don't really love groin access because it just adds an additional thing to have to think about. So I have two cases here, and both are PAD cases for which I needed to use radial artery access. The first one is a 74-year-old male. He had a right great toe 3 centimeter and a medial malleolar 4 centimeter wound. 2 wounds. He was undergoing weekly debridement. He was a long-standing limb. He had critical limb for many years. His diabetic, but his hemoglobin A1C was 5.6. He was relatively controlled. He was no longer a smoker. He had had previous healed wounds, and he has active metastatic bladder cancer. He was diagnosed in 2018, but it was really not a big part of his life. His wounds in his leg was really his primary issue. He was previously treated at an outside facility. In 1985, he had a FemPop. He had a graft aneurysm, which required an open repair with a synthetic graft placed. He had a coronary history in 1995 with an RCA stent, which I'm not sure, but I'm guessing was a groin access. He subsequently had a CABG in 2003. And then he had a right common iliac stent, and then he had another right and a left common iliac stent. And then he had a TIA with an open carotid endarterectomy, possibly a carotid angiogram, not sure, but could have been additional access in the groin. At one point, he put on compression and his graft failed. In 2008, he had a graft pseudoaneurysm vision, which was a 7-hour surgery done by one of our longstanding vascular surgeons who was exceptionally skilled at open surgery. And he just remembers that it was unsuccessful and it was a very long surgery, and this very skilled surgeon said, "Don't ever let anybody operate on you ever again." And then in 2017, he had a right femtib cryovein graft. He was also told me that someone tried to cross my iliac system at some point with a wire, but it didn't work. He, of course, blamed all of this on Agent Orange exposure with just poor healing and heavy scarring. Here's his pre-op ultrasound. So you can see here that he has a flush occlusion all the way down to his midfemoral artery, and he has this really large undulating aneurysm. That PTFE graft was the first graft that he had placed that had occluded, and then you see the occluded vein graft, and then you see the occluded posterior tibial and proximal anterior tibial with a collateral coming off of that little open popliteal as well as the mid-posterior tibial. And he's really getting all of his flow through his profunda, which was quite hypertrophied, but there were elevated velocities in the profunda to 279. So this is a guy who was very reasonable, who had been through a lot with his foot, and he just said, if this is the end, this is the end. But where do you amputate here? Transmetatarsal probably is not going to heal. BK is probably not going to heal. I don't even know if an AKA would heal with this arterial supply. And remember, he had iliac stents, which hadn't really been thoroughly evaluated. So he incidentally had a acute non-occlusive popliteal DVT with a floating tail, So another thing that is kind of interesting to think about with arterial disease is the stasis and the flow through the venous system. And this got me to thinking that, maybe with diminished flow through the arterial system, there's diminished flow to the deep system. And was this another sign of how bad his arterial flow was? Anyway, he was on Plavix and aspirin. So I promptly converted him to Eliquis, and then I also placed an IVC filter, knowing we were going to have to somehow tackle this leg. This is his CT that was done in an outside facility, and you can see there, this is his good side with a little narrow window of his common femoral artery, which I felt like I could probably hit without a problem between the calcification. However, he did have quite a belly there, and as Parag mentioned, these obese groins are a little bit of a nightmare. He also had this hostile groin, which didn't look bad on CT, but on physical exam, he had scars, and I also had read all of his op reports and knew what a hassle his groin was going to be. So I also really wanted him to be on as much anticoagulation as he could be because of this floating tail DVT. So I went radial. I use radial quite a bit. I love radial access. To me, this was a no-brainer. His left groin would have been difficult. His right groin was not an option because I was trying to get in profunda. His tibial was possibly an option, but only to open up to the popliteal. So, it takes me about a minute or less to get down into the pelvis. I placed what I normally place was a 5-French slender sheath. And then I always administer a radial cocktail, heparin 3000, verapamil 2.5, and nitro 200. In this case, I had subsequently exchanged for a 5-French 55-centimeter working sheath. I usually just do all of my body interventions through the 5-French slender sheath. I think with radial, a couple things I've learned over time, I'll go smaller than 2 millimeters. I think 0.6 millimeters has been the smallest radial artery that I've accessed. But you have to work really fast and you have to avoid catheter exchanges. So I try to get, the catheter into where I need it to be, and I park it there, and then I don't, really move a catheter in and out a whole lot, which means that if you're trying to drive into a certain artery, you can't really take advantage of all the wonderful catheters you have on your back table, because you kind of get one or maybe two. I think an appropriate time for a radial case is maybe 45 minutes to an hour. I think it starts to get really tough. After that, with patient positioning, and I worry about their shoulder, I do left-sided access with the arm out. So I don't do any of this crossover stuff, but they just kind of have their arm out. So I think that there are some limitations that way with radial, at least now, although I have not yet had a spasm case where I've had to convert to groin. Another nice thing that we do that I've kind of learned through the process of failure is I like to warm the saline. We put it in our blanket warmer. And I always am wiping the glide catheters. As I'm pushing in, I'm kind of wiping the catheters with a warm saline. And I avoid braided catheters entirely. So just anything that is very glidey and with a nice warm saline. Another thing is that after I do like the radial cocktail, I avoid injecting cold saline. I just think that that's, I have no evidence for it, but it's in my quest to avoid spasm, I just sort of had this concept that a cold saline injected into a small artery, it just seems like it would cause spasm. Just like if you put a cold towel on your foot, everything vasoconstricts. So I don't do large volume flushes in and out like you might in a femoral access.
Right, let's stop there for a second, 'cause I think there's so many great pearls there that I want to make sure to talk a little bit about. First of all, the radial cocktail. Do we all use radial cocktail? I think we all go ahead and use a radial cocktail. And the 3,000 of heparin, a lot of times there's a question, well, did you already, the patient heparinize, already on heparin? I really don't. I give it anyway. I usually think the more the better. And I'm not concerned about bleeding when I'm doing a radial approach. So I don't know if you guys agree with that or not.
I am absolutely not concerned about bleeding with radial approach. I'll do them on whatever sort of anticoagulation they happen to be on.
I love your point about the working sheath. So tell me about this 5. It was a 55. So that gets you. Where does that get you?
About right here.
Get you
Not
right
far
to
enough.
the proximal ab.
Beyond low enough where. So I've done cases where I've injected through a pigtail catheter to do an aortogram, and the pigtail will fly up and go into the heart. So there's something about the pressure column of the contrast through a power injector with these floppier catheters. And what happens is, so if I ever do an aortogram, I'm always watching the tip of the pigtail. It's not off the top of the screen, so that if the pigtail does, I've had it happen twice, pull up and actually go into the heart, I'll know that it's not there, and then I can promptly move the II up and see it. So I do try to get as far down as possible. I think with the sheath, as long as you're really below the diaphragm, and the goal for me is that not to be moving in and out with potentially going into the SMA, which the SMA will come down right at the midline, and there's really subtle changes in the wire that tell you you're in the SMA. But it's really easy to go into the SMA, or not so much a celiac, but definitely the renals. The renals is more obvious because it comes up, but the SMA you can go almost all the way down into the pelvis. And if you don't really see these subtle turns or pay attention, so you shouldn't have any pushback on your wires at all. So I think for people who are starting to do radial, that really paying attention to being below the SMA is important.
I think once you put that sheath in, basically all your exchanges through the arm are going to be through that sheath, right?
Yes,
so you've minimized any of those things that you talked about.
Yeah, you don't get to take that sheath in and out. Once the sheath is in, so you got to pick the right sheath, and you can't just be off by 10 centimeters and put a new sheath in. No way. Like, you got to pick the right one and park it and do everything through that.
So I think that's a huge learning point, right? The planning ahead of time in these cases is really important, right? You already have an idea what you're going to use. You may use your first run to say, hey, is what I think is there, right? In this case, is that profunda really going to be tight that I'm going to treat? And then once you confirm that you're putting down everything and you're ready to go. What would you say, Parag, in terms of...
I think those are great teaching points, and you learn that by experience, falling a little short and then needing to exchange. And so, but I think that's the area where case planning comes into play a lot in these cases, right? In advance, thinking about what devices I'm going to pull, what lengths, wires, and this gets back to the earlier talk of when it works, when it doesn't work. It's thinking ahead, what am I going to need? Because you don't have the luxury of unlimited exchanges. You've already pointed that out. That's where you run into problems.
Another thing about that is I've learned I look at people differently now with radial, because first of all, when you see them in clinic, they're sitting down, and it starts to make a difference how tall they are and their arm to pelvis length. So I look at like leg length kind of differently. And I'm always analyzing, are people tall from their hips to their shoulders? Are they tall? Where are they tall? Right. Because you can have two people can be sitting next to each other and appear the same height, but one has really long legs and one has a really long torso. So torso height has gotten me a couple times. And I have been, working, especially on a fibroid, and I'll come to the realization that the patient is a lot taller than I thought they were, and 5 centimeters can make a difference. So, got to look at people a little differently.
Let's go back to your case. Thank you.
Okay. So anyway, I was going for the profunda here, and I just decided why not. I was going to take out all of these tools, and I sort of had to rethink how I view this profunda. And it's a little dicey because you're in this single artery, and that's it. And I hadn't seen anybody do this, but I just figured I had to open up this profunda. I also was using real-time ultrasound, which was really great because there was an aneurysm there's an aneurysm right there in the common femoral artery. And so my goal was to treat that calcium, but not get the Phoenix device spinning in that aneurysm. And so I used ultrasound to advance my Phoenix device right up into the chunky calcium, and that's how I knew exactly where I was. Because you can see the angio's tough. Remember, this guy is really big. I'm hand injecting through this 5-French catheter. The arrow there is on the piece of calcium, which you can see with IVUS. And so I really did use IVUS to confirm this. So anyway, I used IVUS, I used Phoenix, and then I ballooned it to 6 millimeters. By IVUS, the stenosis reduced to 25%. I was super happy with this. We also were doing PAT at the time, which is something I've been talking about at the conference, but we're looking at foot flow. So we knew he had a class 4 foot, and I really wanted to try to get him to class 2, which would have indicated wound healing. So I had access into this posterior tibial. This was his original, so I did go tibial as well on him, hoping to make it up to the popliteal so that it could get a little more of that collateral flow. I couldn't make it all the way to the popliteal, so I just took what I could. I ballooned it. I realized this was probably going to go down, but again, I just wanted to, see what I could do with it. His PAT did reduce to 142, which is class 2. So, I really think these people who live off their profundas, why not have radial as a primary? I mean, it comes off at the best angle. It avoids these big groins. We already know their vascular paths if they're living off their profundas. And what's great about radial is that all of that calcification that affects the tibials and the groin vessels doesn't affect the radial. And then also, I'm always a big fan of knowing your endpoint. So on this guy, having a class 2 reduction, I could actually give him some pretty good news afterwards. This is a second case.
Before you go there, 'cause I think you brought up so many great points. This is a patient which I consider, radial by necessity, right? There's radial by choice, which is, I think, all the abdominal stuff we do by choice. Patients ask for it, we like it. There's a lot of reasons to it. This is someone where like the groins were really out, right? Yeah. And you're thinking about if something, your bailouts, what were your bailouts? Obviously, you're very careful. You're using all these different techniques to be available. And being in the profund, you can probably still have some bailouts available that you may need. But I love going pedal because I think that, as we move forward, because of the long links and because of the things that we don't have, obviously this patient is very complex, right? And you're not going to be able to really externalize a wire. But in theory, you could have the opportunity where you could have externalized a wire radial to pedal and just worked over that wire.
Yes.
And now everything becomes available, right? With two small or, basically puncture. So it's very interesting.
I think some of the tools that we think about in pedal are the same tools we think about in radial. So to your point, between the two, you actually bridge the gap or the gaps in devices that you have on the shelf between the two access. You were able to treat both. You probably used, some will use a cocktail with their pedal access too, so I don't know if you did that or not, but there are certainly those who will advocate that, and they borrowed that from the radial literature, and then likewise some of the wires and devices that you just can't reach from radial, now you can do from there. So I think that was a great case because it showed the utilization of two small bore access to actually accomplish a really challenging case.
Yeah, I actually do use a radial cocktail for tibial access. I also watch the clock, so I try to keep my tibial access, my sheath, in less than 30 minutes. And this, I guess, comes from my radial experience that I view it as a more complicated radial artery because it carries with it the disease, also potentially not the other tibial vessels. So at least you have a patent ulnar and we have a Barbaro. I mean, why don't we do Barbaro tests somehow on the foot? So I view the tibial as a complicated radial, and I work as quickly as I can. As soon as I get through maybe a CTO, my staff knows we get that radial or the pedal access out, and somebody will hold pressure, and I treat the tibials as a very vulnerable arteries. I'm hoping one day we have a world where everything is tibial and radial, and we will look back and be like, wow, can you believe in 2020 we access that groin? I also do think this is why even people who are not radial first or centers that haven't developed the radial expertise, that it's such a great bailout vessel that really being very fluid in it is a skill set I think every IR should have, whether or not they plan on using it routinely for body cases.
Yeah, I think you're 100%. And as we start getting more of the tools, people are going to be able to have those tools available. And you're right. Go back, is it necessity or is it choice? And I think as you start getting more of the necessity, you say, well, why don't I use it for choice? And you start expanding like we did in other areas. Yeah. Great.
So this is another case. This was not my most fun case. 55-year-old diabetic. He had 3 right foot ulcers. He had fat exposure, recent hospitalization for cellulitis. He did not have osteomyelitis. His GFR was 30. I'm often working on people with low GFRs. I use a lot of IVUS. I use IVUS on almost every single case, and I really try to keep contrast dose to between 20 and 30, and sometimes as low as 10. I think 4 is like the lowest I've ever gone. But I try to use a lot of ultrasound, both externally and IVUS, to try to keep the contrast doses down. So he had a left lower extremity angiogram. It went great. We went to put a closure device in, and it didn't really work. He kind of had a hematoma, kind of didn't. This just sort of went on for about an hour. And anytime we lifted pressure, he developed this hematoma. But he was obese also, so it was kind of a dicey groin. I held intermittently with my tech for about an hour, and clearly this problem was not going to go away. Of course, it was October 31st. We no longer do cases in our lab on October 31st because 2 years in a row we've had these types of things, and we decided it was probably the date. So I pulled out the ultrasound, and now we're at 6 o'clock at night, and so I'm doing ultrasound. My ultrasound tech's not there, and he has this large, kind of vascular mass, and through this big groin with holding pressure, it looked like a pseudoaneurysm. But I didn't want to inject thrombin just in case it wasn't a pseudoaneurysm, and I didn't have a really clear understanding of what was happening. I didn't think that I had hit any little branches, but I notoriously go in. If there is a little side branch, I will hit it on the way in. I get in these like little weird things all the time, and then I've got to get into femoral. So I was thinking, did I go through something, or was something wrong with my access? So I wasn't really sure, so I didn't want to inject thrombin if he had actually just had a big hole in his femoral artery. So I thought about it, and I thought a little more. So then I decided I had to do something. I did not want to transfer him to a hospital. I felt like I just needed to handle it. He was obese. He had already had one groin issue, so I could have gone in the other groin, but I just felt like that would open a whole nother can of worms. And I didn't know at this point if it was a pseudoaneurysm or if I caused a branching vessel to bleed. So, the benefits of Radial is that I could just get his wrist prepped and draped, and the tech could hold the groin the entire time. I could get the catheters, the wires, the balloons right up to the femoral artery while we were holding pressure. And I could also avoid a second groin access, which after doing this session, I'm realizing how much I actually hope all access is radial and tibial in the future. I don't really have great angios from this case, but here, this is the case. You can see my access. The fact that I have a REM catheter out means my wire wouldn't go down into the femoral artery initial access. But the pictures on the right, there's a catheter from the radial artery into the common femoral artery. And what I did is I parked a balloon right over the access, and I blew it up, and then I did regular ultrasound, not IVUS. And I watched the aneurysm appear and then disappear with a balloon up. So the ultrasound really looked like a classic pseudoaneurysm. And the fact that I could just control it by blowing up the balloon and blowing it down, blowing it up, blowing it down, gave me confidence that I could blow up the balloon and then inject this thing with thrombin. So what I did is I blew up the balloon, I got the needle into it, I released the balloon, and then I injected thrombin, and I watched it go away beautifully with 0.1 cc's or something, very small amount. So that was really great. And then I got the catheter out of his wrist, and that was it. His wife, meanwhile, was completely freaking out, and so I managed to sort of control the situation and have him come out with just a band on his hand and not introduce the groin access issues on the other side, which would have required another several hours of recovery.
Well, I think that's another great. I think it's great for two reasons. First, obviously, being able to get that patient home that day. And the second, being able to avoid the groin. Like you said, like we have a lot of times, and I mean, think about, we get called a lot in the hospitals, patients that had puncture for something else, right? And they may come the day or the next day or 2 days. And a lot of time in those, we require a bunch of imaging studies, and then we go up and over, and then you're like, okay, is it a surgical case or something we can do? Being able to go immediately from the radial, have both groins to your disposal, I think is really, really helpful.
Well, then you ran the risk of complicating the other groin, because it wasn't that his obesity was unilateral, so you would have had the access on the other side to deal with. It was a no-brainer and a great use of radial access to solve this.
I think it's our biggest, at least one of my biggest concerns is the whole, hospital, the dumping ground of the OBL. I mean, it's really incumbent upon us to deal with our own issues and not just, ship people off to the hospital for other people to deal with. And imagining that guy in the ambulance, holding pressure for something, I really think we need to all have the skill set to be able to be creative. I mean, of course, if people need hospitals, they need hospitals. That is something that happens in OBLs, though, is you don't have the default of, let's just admit them and see, or let's watch them for a little bit. Like, you really do need to be able to deal with these things pretty quickly.
Tell us, you've given us 2 great cases. You talked all of this, really great things about radial and the benefits of radial, but never did you say, hey, because you're in the OBL, you see that advantage. Tell us a little bit about the obvious advantages in the OBL to go radial in terms of patient satisfaction, in terms of being able to get you could probably do cases up to 3 o'clock and still finish at 6. as opposed to if you do femoral case, a lot of times you finish by 12 because you got to observe those patients. Give me some of that. Give me some of that.
This
'cause
is
I know
really,
you know that.
Yeah, this is interesting because my ultrasound tech, who is fantastic, works also in a hospital with some vascular surgeons who do really complicated cases. So last week I had several CTOs that were really long cases, and my staff, everybody was like fairly exhausted by the end of one of these days. And you know, I'm working so quickly that I questioned her. I said, what is it like in the hospital? Am I running this room too fast? Am I working everybody too hard? Am I contributing to the exhaustion by being like, go, 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 go? And that is a little bit how I work, but I can't kill my team. And I really felt like I killed my team and myself, but I can take care of myself. And so they had the next day a similarly complicated case in the hospital. And I asked how this surgeon did it, and she said, no, it's really mellow. There's music going, and it's a 4-hour case because there's no urgency. They don't use closure devices, so there's always a 6-hour recovery. And if you finish anytime after 5, 6, you just admit a patient. And so I think there's a much different mentality that I am all about getting in, you got to get the case out, you got to get the patient recovered. And when you take too long, it's when bladders start to hurt and people start to move, and then you get motion. So they're doing, a 4-hour case with anesthesia, with an overnight hospital stay, just because things kind of go on that long. And I try to keep cases to like an hour and a half, build in an hour recovery time, and then they're out the door with groin access. Certainly with radial, you can put a radial device on and people can leave in 30 minutes. And we keep them longer because usually it's UFI and they just hang around, but they're just sitting there. We order them lunch, they Grubhub themselves, whatever they want. But yeah, for the OBLs, not introducing the groin access complications is huge because I obviously can't do a cut down. I can't do any surgical revision, so.
We really, I think, highlighted the benefits of that access and being able to treat from an access. Okay, I'm going to show a case, and this is a woman with severe claudication. So it's a 69-year-old woman, and she came to see me because she was having severe left calf claudication. She basically said, at 50 feet, it's gotten worse over the last 5 months, but I just can't continue like this. She has hypertension, dyslipidemia. She did agree, she did tell me that she does smoke a few cigarettes a day. She told me 4 to 5, whatever that meant. She does have a complicated past medical history. Bilateral iliac stents in 2017, and then she had one in 2017 and then had bilateral in 2018, and then a left SFA stent that she had first in 2016, and these were all done in an outside institution. So she came to see me on a baby aspirin, on clopidogrel, and atorvastatin 80. Those the bilateral iliac stents. What does that do to you when you hear that? What do you
Makes me think radial.
Think radial, right? Gives you an opportunity to see both legs from one access. Who knows where these stents are? Are they high or low, right?
Yeah, 2017, 2018. We've learned a lot about stents, even since that time, and stent configuration, radial mismatch, crossing. Certainly up and over is less likely to be a feasible option. And then, like you said, you can see both legs really nicely from radial. So
on physical examination, really uneventful. She had on the left, which is her symptomatic side, she had only by Doppler could I hear a femoral popliteal DP and PT. So everything was by Doppler on the left. On the right, she did have a palpable DP. There were no ulcerations and no skin changes. And we can see the arterial non-invasive examination. So on the left, the ABI was diminished, 0.68. You can see some flattening, pretty much in the metatarsal area and but otherwise looked pretty good, I think, at rest. But when she exercised, you can see that it was completely decompensated on the left. So basically flat waveforms at the ankle with very minimal exercise. So confirming what she had said. Looking again with ultrasound, we saw basically the distal popliteal artery. There appeared to be this stent, and it looks as though there was some increased velocity within that stent, and maybe something on the other side of that stent. I'll show you the picture of what we're looking at, and really that's our challenge. And then on top of that, there's a question of maybe some increased velocity in that common femoral artery. And I think the common femoral artery sometimes can be difficult, right? Probably a site that's been punctured multiple times with all these other procedures. Yeah. It's an area that, can affect, because if you get something in the high common femoral or in the common femoral could affect the profunda and the SFA. So that could be giving symptoms too if it's kind of chokes off both the supplies to the leg. So my plan was a left femoral popliteal intervention. So what do you guys think? What would you say to this patient? How would you approach this patient? Is this, obviously, do you start right up and over? Do you go straight to a radial? Any other access points that you think about?
So I think radial's reasonable, but to get down below the knee, you really have to think about what wires am I going to need? Once I get across, am I doing something adjunctive? Is it strict angioplasty and stent, or am I going to use something like atherectomy if you think there's some in-stent restenosis? Do I have the length and the size profile that radial can accommodate? These are kinds of things I'm thinking about in the case planning. So you're going to intervene. This isn't just diagnostic. You have something to intervene because you've got good mapping and good non-invasives to direct you. But those are the things I'm thinking about next.
Mary, you?
I would think about that too, and probably be thinking tibial first on this. But with the in-stent stenosis, if you are using an atherectomy device, depending on which one you use, you could require 7 French access, unless you have certain other devices. Right. But I would look at the tibials first, but I think the radial is a great case on this, depending on how low you're going to go and what device you're going to use.
And I was thinking at least I can get to the common femoral, I think for sure. I can look at everything, see how bad that is, treat it. Mm-hmm. We talked a little bit about puncturing the foot if I needed to, and maybe externalize a wire. I think you brought a great point. What devices, right? What do I have? We have stents now in a 250 for tibials, so I could go from the radial if I needed to. But I think it really highlights the homework, right? The planning. Don't walk in not having a plan.
Exactly.
Because I think Mary's, basically your 45 minutes will be stuck thinking and not working.
Exactly.
All right, so I just went and did a fluoro when she was on the table. And I don't know how well that projects, but basically the stents not only are high, they're all crossed and they're like, I have no idea what's going on here. It was, it was so bad because part of me said, look, if it's iliac work, I can just dilate those stents and get out, right? Like I said, let's not forget about, maybe I can just make it better by dilating those stents, because obviously it worked before. But I did access the right just to really see what's going on with the iliac, and then basically realized there's no way I'm going to get to the left from the right. Measured the pressure, and then said we have to go radial, which is what I had told her. We're going to go radial. But I just wanted to make sure that I wasn't missing some easy iliac disease that I could treat from this side. So, but radial approach, and you can see here an ultrasound. I'm assuming, does everyone use ultrasound for the radial puncture, or? Mm-hmm. Okay, and I heard people talk about the size of the radial artery. So I think I use ultrasound really for that the size, and depending if I need it to puncture or I can just puncture blind, but I get to at least know where it is. Mm-hmm. And then access with a micro wire and put in, and I usually put in a short sheath, a hydrophilic sheath, just to get down into the aorta. Once I get into the aorta, I go into and get something larger. Yeah. So you can see here crossing over. And a lot of times, depending on the catheter that I usually go with an MPA catheter when I'm going here. So I'll use a 150 kind of glide, kind of hydrophilically coated catheter with an MPA shape that's 150 centimeters. Can serve kind of as a crossing wire, can get me into, and has kind of an MPA shape. Yeah. So I can get in the right leg or the left leg if I need to roll, kind of run either one of the legs off, and at least get the action to the aorta. You kind of scared me with about flopping, if it flops all over the place. That's something now that I'm kind of more worried about, because a lot of times you know what you're going to do. So going ahead and putting in a longer sheath, it's probably okay to do that now. But we got that catheter there, and we took pictures running off the vessel. So I saw that common femoral artery had several areas of really calcified plaque in that area, and I kind of measured a gradient along that. And then we saw that area of in-stent restenosis. And you can see there's an area of in-stent restenosis along the distal aspect of that stent, almost at the edge of the stent, and then distal to that stent, there was almost like another piece of this plaque that was distal to that.
Hey, Tino, let me ask you, how was the iliacs? Were they okay?
The iliacs were great. So we measured pressures, and the stents, even though they were all kind of But I think you're right. You got to make sure your iliac's, because if you can get iliac work done,
Yeah.
you're done, and you can hopefully, maybe that's enough to get that patient better.
Did you happen to IVUS this?
I did not IVUS this. And I guess an IVUS would be over the wire, so it should be able to reach there. Which IVUS do you use to get, because I saw in your case you used IVUS.
Phillips.
Is that Phillips wire? It goes all the way
018.
down? Okay. So an 018 IVUS, something we could have done. We did not do IVUS on this. I probably could have gotten an IVUS there. So this is what we see below. So at least there's at least 2 vessel, tibial vessels, with the PT is kind of small, but I think it's there, and a good view of the foot. So really looking at what I thought was that area of in-stent restenosis with that area in the proximal popliteal, and maybe that common iliac area, lesion. So I went ahead and now I placed a sheath. So we used the sheath and got that sheath down into that iliac artery. And first looked at that area. You can see how calcified, there was some calcification there, that plaque, you can imagine just from that initial run. I said, what I really want to do is see if I can improve this gradient that I had here and dilate it. So I went ahead and, using, at this point, I had an 035 wire and went ahead and treated this area with a balloon. So, in terms of technology that we have, we can have, I could have reached here maybe with a 150 shaft, but, my balloons are going to be in the 035 are going to basically go to 135. It's going to be
I wanted to ask you here, how much length did it take? You had a 200 centimeter length delivery system. You didn't need all of that.
I didn't need all of it, and I think.
Would you have thought about other adjunctive besides plain balloon angioplasty, like a
right? That's the question, right?
Or some
I think my level is 130.
Common femoral, right? So.
Right. So if you get to 130, a lot of times what I would do if I wasn't radial would probably be looking at some type of shock wave. So that's a 120. That's a really short delivery system.
That's not gonna get there.
Talked about atherectomy. We do some, but probably very minimal atherectomy. So the question is here, how to treat this and how to kind of get it better. And then the question of durability, right? So you talked about drug-eluting technology. We don't really have a lot of drug that's going to be long enough, in a shaft. So here I went ahead and treated this with a 7 millimeter. So going to 7 millimeters, you're kind of limited, I think, into what's available. So we used rapid exchange technology and treated that. And I think here I was just trying to create some improvement and not really create an issue, because I think stenting in this area is an area that I don't want to stent.
Right.
And I don't have a lot of options to stent, right? Because a 7, I want probably at least an 8 stent. My self-expanding stents are going to be in a 130, system. And these are all the things that we talked about, the homework. You got to have your homework. What are you going to do? You can't go from the other groin. I could deliver a stent from the pedal, but those are 7 is the largest I can get. So I would kind of be very kind of tight as to what.
Do you still have access in the other groin?
I had a small 4 French sheath in the other groin.
4 French sheath. What about fixing the distal disease and sending her for endarterectomy?
Okay, I think you're right.
Artery.
How significant is that, and can we get endarterectomy? I thought it was bad, but I didn't think it was the whole problem. But I think that was in my, if this didn't look great or if I wasn't making any improvement, I think I would go, endarterectomy definitely for a common femoral. And then once I do an endarterectomy, I think, I could basically at the same time, I can treat everything, right? I can go check my iliacs again if I wanted to, but then I could, at the time of endarterectomy, go down and treat everything from the endarterectomy. So I think that's definitely an option.
And were you thinking about the need to stent this following angioplasty, given the calcification in case of a dissection? You probably don't have to do this. I have to think about just stenting following,
right?
With such a calcified, with that, because you have a 6 French sheath in. So, I always, with the calcified lesions, I just feel like inevitably they dissect.
I think that's exactly right. What are our bailouts? Right? I asked that at the very beginning. What are our bailouts? And I think our bailouts here are very limited because I can't use the other groin. I guess, you could go a popliteal to do a bailout, but, you saw what's in there and there's a stent.
Yeah.
I think our bailouts would be very limited. It would probably be some alternative plus access, I think, if we had an issue, which I think raises a good question. Hey, should we be doing this or should we be watching and maybe go to surgery? But again, I went to a gentle balloon really because I want to make sure I can get some inflow to treat what I think was the culprit area down below. So I don't know if this video runs. Is that video running? But you can see on the right that there's a video. I'm trying to get this wire across that kind of calcified plaque in that proximal popliteal. And, I think to me, going back to what Parag said, our limitations on length, but also our crossability and torqueability, very limited down here. I mean, you feel like you're way back out there. My 150 catheter, I'm not going to be able, it's not going to help me. Okay, and when I'm looking at a system like this, a lot of times you're looking at something rapid exchange. So it doesn't help you to give you that much, that much help to cross a lesion and then to get across a lesion. And I learned that really, I think, on this case, because this one it didn't look that tight, but it was tight. Yeah. I got the wire to cross, and then I got the wire down, and now I had to cross the balloon, and I don't know how well you can see this video, but basically you can see the balloon going there, and this is like, I haven't inflated this balloon, so it's totally down, and just trying to get that balloon to cross, and you can feel it kind of go blump, like, across the plaque. And then I pulled it back to treat. But that's how I say, okay, this is really a tight area. It didn't look that tight, but it's a really tight area.
And that's the worst, because you feel like you're pushing it, which means it's probably buckling somewhere else, right. Destroying something above, when you're trying to watch it, and you're doing something with your hands, with those tight, from so far away, the give is somewhere.
And that's why you're hoping on your sheath, right? You get that sheath as low as you can, right? You use, that support of the sheath, get it right to where as low as you can, and then, like you said, you're gentle. You're getting the feedback. Okay, I've done about 2 centimeters. Where is those 2 centimeters right now? Okay, let me release it. Let me try again. It's kind of like you don't want to keep pushing. You want to push back and forth until it kind of goes. And I was lucky that it actually crossed. We were then able to dilate. And again, this was a rapid exchange over an 018 system, and then again, went back into the stent and treated the stent, and we had that kind of result. And again, I think if I was femoral, I probably would have been trying to get some drug delivery here. So I think there's a call for, hey, we probably need, as soon as we start developing this technology, having a 200 centimeter balloon, you need a 200 centimeter balloon with drug if we really think it decreases intimal hyperplasia.
You bring up a great point. If we believe in that technology and you're using that from a femoral approach, you shouldn't limit what you're able to offer patients just because you chose a radial access. But the device options right now limit us. And I think that's part of, when we're making our decision tree, it gets to that point, especially when we're looking at peripheral type interventions.
I wonder if the future of these devices is interchangeable catheter lengths, that instead of having 20 lengths of like the Phoenix, you have one Phoenix device with interchangeable catheter lengths that you can then select. And that's how you get the full spectrum of, or you have an adjustable length.
So you can have one SKU, right? One thing on your shelf, especially in OBL. One thing. Even in the hospital, they limit us to how many things we have, right. And then that it could treat pretty much almost all patients, right? I think you're right. And that's a technology that we're probably going to need. And then I went back and used that 7 millimeter balloon a little bit better on that common femoral. You can see that inferior epigastric. I'm kind of watching that very carefully. You want to treat below that. I didn't want to get anywhere near the profunda. And I kind of just brought it up and just held it there for a little bit. And I was very happy with that result. So post-procedure, she did very well, non-invasive. I usually perform this about 4 to 6 weeks afterwards. By then, I pretty know if they're doing better because I call them the next day, and they usually tell you how well they're doing and whether they're ambulating, and they see the improvement.
Nice case.
And then a walking test, that's really where she failed before, and she was able to tolerate that well. So that was my case. We have a few minutes left. What kind of points? We talked about our objectives here, talk a lot about the importance of radial access, the benefits of using that access. I think we've talked a lot about them. How would you summarize some of these points?
I think some of the things I heard that are great take-homes is that radial access obviously is here to stay. I think we've seen the evolution from radial to coronary, radial to non-coronary, and now radial to peripheral. We see it easily used in the pelvis for non-peripheral type cases, whether it be body type cases. We use it quite frequently, but it's a great tool for iliac or common femoral type or profunda lesions. The same type of access that we use for radial is the same type of access techniques that we might use for pedal, and so the combination of the two really can get us to the full gamut of disease, lower extremity disease, aortoiliac, fempop to tibial, but we're still missing a number of things, right? So if we believe a standard of care allows us to use a drug technology, a drug delivery technology, whether it be by balloon or by stent, then we really need something that's going to allow us to do that from a radial approach or perhaps a pedal approach, a low profile. And I do think that there are some devices we still don't have, like reentry devices and stent grafts, that just don't meet the device profile from a radial access currently.
Mary, any thoughts there?
I would agree. Well, as you're speaking, I was thinking back to the people who used to do the direct aortic puncture, and wondering if in 20 years we'll look back and laugh at the times that we did the femoral artery stick. And I think this is an exciting time for device development to address some of the things with the torqueability, and just being able to figure out, to not have more product, but to figure out how to use like the tools we already have in the best way. So are we going to need to develop products that have a torqueability, some engineering that's different for that directional need that we have? We have a need to be able to direct our catheters and wires and push them. So I think it's really exciting, and I think that leaving this, maybe I'll start doing radial first PAD. We'll see.
I think that's where especially when we get the tools. You're exactly right. Well, I'd like to, again, thank all of us here, or thank by the faculty. It's fantastic, great discussion.
Thank you.
And I'd like to thank again the CME providers, and again, Cordis for the grant for having this CME activity. Thank you very much.